by the end of the day. Really, I have the honor to present the next speaker. The next speaker is Professor Abdallah Geara. Professor Abdallah Geara, he was graduated from Lebanese University Faculty of Medicine in 2005, and he has a training and fellowship in different places actually. In Lebanese University Faculty of Medicine from 2005-2007, in Richmond County Medical Society from 2009 to 2010, in Columbia University from 2010 to 2012, and lastly, his training is in the glomerular and onco-nephrology fellowship in University of Pennsylvania, and his current position as a professor of clinical medicine, University of Pennsylvania School of Medicine. And he has many editorial positions actually, from 2018 in the Clinical Nephrology Journal, editor in the American Journal of Medical Science, editor in the American Journal of Kidney Disease, in the Clinical Transplantation Journal, in the Therapeutic Everses and Dialysis, Kidney International Reports, Clinical Chemistry and Laboratory Medicine Journal, and the review editor actually in the Glomerular Disease in Frontiers of Nephrology. So please welcome Professor Abdallah. Professor Abdallah, title of presentation will be about the magic cell, the podocyte, and the title of his presentation is about podocytopathy. So please again welcome Professor Abdallah.
Thank you. Thank you, Doctor. I just want to make sure I'm having a problem. Are you seeing my slides?
Yeah, yes, sir.
Okay, is this, I'm just switching to like full screen. Do you still see it?
Yeah, I can see it. I don't know if other audience, I think. What about Mamdouh, Mustafa, and others?
Yes, we can see it, but in
the presenter view.
Yeah, in the presenter view, not the full screen.
Okay, so let me try to do this.
But it is okay, whatever.
Okay.
Dr. Abdallah, you can make a new share and choose to share part only of the screen, not the whole screen, and localize that part on the slide part in the presenter view.
Okay, is it working now?
Yeah.
Yes, it is working.
Yeah, that's good.
Okay, good. So thank you for this presentation, Dr. Sabri. So I work here at the University of Pennsylvania. I'm the medical director of the Glomerular Center at the University of Pennsylvania, and we do deal with a lot of glomerular disease. And one of my job, I feel like when I'm teaching and when I'm presenting on the glomerular disease, is to just try to identify how much we can get from the pathology when we do the kidney biopsy versus how much we can get from the clinical, and try to just emphasize the most important point that I would like you to take from this presentation is how much the pathology does help us and how much the clinical presentation also is important in order for us to come up with a plan for our patient on how to manage. So these are my conflict of interest. None of them is related to what I'm presenting today. The objective of this presentation, the presentation is focused on adult with primary podocytopathy. We're going to mention a little bit about the children with podocytopathy, but since this is my field, adult, so I prefer to talk about adult. There is some variation with the podocytopathy when it comes to kids. We're not going to get into details about kids. As far as primary podocytopathy, I would like to start by defining what we're presenting here. Podocytopathy are diseases of the kidney that are due to immune-related injury of the podocyte. So what we're talking about the podocyte that's injured here. And that's how we're gonna get the histologic lesion. So traditionally, we subclassify these entities as minimal change disease or FSGS. But the most important thing to take from this presentation is actually, regardless of how the histology looks, the pathology or the pathogenesis is a podocyte injury. Okay, and we're gonna focus on the immune-related podocyte injury. What do I mean by the immune-related podocyte injury? Sometimes you hear talking about primary podocytopathy, which means that the podocyte is injured by either with T cells, we think it's T cells or B cells, but the podocyte can be injured in the kidney from other etiology. For example, genetic. For example, if you have podocin or nephrin mutation, that will injure the podocyte. Medication-induced. Common medication that are frequently mentioned here are like bisphosphonate, for example, interferon. Viral, for example, COVID-19. Recently, we found a lot of podocytopathy due to COVID-19, paraneoplastic in the setting of lymphoma, leukemias. So all of these etiology or pathogenesis can lead eventually to the histopathologic image of minimal change disease or FSGS. We're not going to get into these entities. We're going to just focus on the idiopathic or what we call primary podocytopathy that can present on the histology as minimal change disease or FSGS. So this is only to situate where we are today. So what is minimal change disease? As you can see, minimal change disease, and by the name, is a lesion of the kidney where when we do the biopsy on the light microscopy, the glomeruli is perfectly normal. So this is glomeruli that looks normal. I mean, the capillaries are open. This is your urinary space. Your urinary space is intact. You don't have hypercellular. The mesangium is intact. So the light microscopy is perfectly normal. The IF, immunofluorescence, when we try to look for either antibodies or immunoglobulin or C3 or other complement pathway molecule, they're negative. So we do not have an immune complex lesion. We do not have immune complex lesion. But when we look at on the electron microscopy, what you will see, this is a normal electron microscopy. And the way you read the electron microscopy, you look at the basement membrane. That's how I was told by our pathologist. So this is a basement membrane. And these are the podocytes. These are normal, intact podocytes. This is a minimal change disease. This is your basement membrane. And as you can see, the podocyte foot process is totally effaced. We don't see these nice digits of the podocyte foot process effacing. So this is minimal change disease. So the way it's going to present, so maybe someone can need to mute just because I'm having some echo here. So the minimal change disease will show as proteinuria. Thank you. So the minimal change disease will show as proteinuria because these podocytes are injured and will allow protein to leak into the urinary space. The etiology can be autoimmune, meaning B cell or T cell mediated injury, possible circulating factor, and or could be secondary to NSAIDs, as far as example, NSAIDs, or could be secondary to lymphoma, paraneoplastic. That's what we talk about minimal change disease. Traditionally, in some countries, in the United States, we always do EM. In some countries, when you have someone present with nephrotic syndrome, with light microscopy, that's normal. With IF, that's negative. You go with the assumption of minimal change disease diagnosis without doing the EM. So the EM is not routinely done. I know that, for example, series coming from France do not do EM if you have the right clinical presentation with the light and IF that's negative. And I know also in Lebanon, for example, we don't do EM routinely unless we have some suspicion. So what is the pathogenesis of minimal change disease? We always thought it's a B cell or T cell dysfunction, but more recently, actually, the last few months, there was a paper that was published in JASN, Journal of American Society of Nephrology, that is presenting a new concept, and they're talking about something called anti-nephrin antibody. So they look at the cohort of patients that had minimal change disease from the Neptune cohort. That's a cohort of patients with nephrotic syndrome. And they did an ELISA for anti-nephrin antibody, and they did the immunofluorescence for anti-nephrin antibody, and they were able to identify an anti-nephrin antibody on the podocyte. And what they saw, actually, 29% of the patient had this antibody, and as the antibody level goes down, as the patient went into remission, the antibody level went down. So this is still in the clinical setting, still in the lab setting. We don't have anything ready for clinical application, but be ready to hear about anti-nephrin as a potential serologic test in order for us to identify minimal change disease. So in general, we think it's a T cell and B cell dysfunction, and there is a possibility that there's a subgroup of these patients, maybe a third of these patients, do have an anti-nephrin antibody. That's what comes to pathogenesis. So we talked about minimal change disease, which is a histologic image. The other podocyte injury the other histologic image due to podocyte injury is called FSGS, focal segmental glomerulosclerosis. And the term describes the presence of collagenous sclerosis of part of the glomeruli. And the EM does show podocyte injury that's more extensive usually than minimal change disease. So FSGS is a consequence of podocyte injury. FSGS is not a disease by itself, is a histologic image of podocyte injury. This podocyte injury can be multiple as far as etiology or pathogenesis. Could be autoimmune or idiopathic, or what we call primary FSGS. Could be also due to genetic, the most frequent genetic mutation that we see, ApoL1 gene mutation. Could be secondary to viral. We saw tons of COVID-19 related FSGS. It could be secondary to parvovirus, it could be secondary to HIV, and some other virus, CMV, EBV. Drug-induced, I mentioned bisphosphonate, specifically pamidronate, is well known to cause FSGS, for example. Adaptive changes. What do I mean by adaptive changes? These are patients who have injury of their kidney and they have chronic hyperfiltration. For example, someone who's born with one kidney, someone post-nephrectomy, obese patient, and so on. These are called adaptive secondary FSGS or FSGS of undetermined significance. Why is it important to look at this categorization of FSGS? Because not all FSGS are due to immune-related injury. Just a primary FSGS is mainly immune. The other one are secondary to other pathogenesis, and your treatment should be directed to the underlying pathogenesis. You should not go after them with immunosuppression. So going back a little bit to the epidemiology. So when we talk about nephrotic syndrome, based on the age of the patient, the incidence of each of these FSGS, primary glomerular disease can be different. What do I mean by this? When we look at children, the predominant lesion that we see on biopsies of nephrotic syndrome in children, 60 to 70% are minimal change disease. As the patient is moving to the adult side, you can see that minimal change disease become less frequent, and we're seeing here more FSGS and membranous nephropathy. And this is important when we're looking at the approach. When we look at the approach to therapy, traditionally, when we have someone with nephrotic syndrome, if they are children, we move ahead with the treatment without doing a biopsy with the assumed diagnosis of minimal change disease because it's so frequent in children. When it comes to adult, usually we have to make the histologic diagnosis by doing a kidney biopsy because you can be missing an FSGS or membranous nephropathy. So going back to the FSGS, to summarize the FSGS just for last time, and I'll go and because you'll have the dedicated talk about FSGS, so I'll just mention this and then we'll move and discuss only minimal change disease in the next few slides. The FSGS, the main pathogenesis, the main pathology is podocyte injury. The pathogenesis is multiple, and when it comes to giving immunosuppression, you give the immunosuppression specifically for patients who you think have primary FSGS. So after I mention all of this, I'll just start now talking about the management. And this is a slide that summarizes our general thought of thinking in front of glomerular disease in general. As you know, glomerular disease does present either with hematuria or proteinuria. Some of them do have both hematuria and proteinuria. And we do have two major clinical syndromes, nephritic and nephrotic syndrome. So when we're talking about minimal change disease, we're talking about this part of this picture, meaning these patients present with proteinuria, their pathology is minimal change disease, FSGS, membranous nephropathy. It could be also lupus nephritis, which we're not gonna touch about a lot. So this is what we have. And these patients do present with a full nephrotic syndrome, which is proteinuria of more than 3 grams, hypoalbuminemia, and they do have the edema. Additional finding is hypercholesteremia and prothrombotic. When you are faced with these patients, you're gonna start by doing the workup, by serologic workup. Usually the serologic workup is very extensive, where you're gonna look for viral etiology, you're gonna look for lupus, you're gonna look for paraprotein, meaning multiple myeloma workup, you're going to look for anti-PLA2R antibody for membranous nephropathy. But in general, these patients will require a kidney biopsy to make the diagnosis, except if you have a positive multiple myeloma workup or if you have positive anti-PLA2R. In this situation, you might actually move towards the treatment without doing a kidney biopsy. But in adult, the majority of the patients will require a kidney biopsy. So what I do in clinical practice, I do send all the serology, but I do not wait for all the serology to be resulted. I will move to do a kidney biopsy as long as I have the results of the multiple myeloma and the anti-PLA2R antibody back, because in this situation, I can move to treatment without a biopsy. So following the biopsy, we're gonna give the treatment, the appropriate treatment based on the histology. But the important thing when you are facing someone with nephrotic syndrome is that these patients are not at a urgent risk of losing kidney function. And this is very important. So these patients, you can wait a little bit to do their biopsy by few days or even few weeks if need be. So there is no urgency in moving ahead and doing the biopsy immediately. What the patient is complaining of is edema, and they are at a high risk of clotting, that are high risk of infection. So what you need to do, you need to come up with a plan on how to diurese them, and frequently you have to combine several diuretic, a loop diuretic, a distal tubule diuretic, spironolactone, amiloride, in order to diurese them well. Sometimes you have to give them albumin to assist with the diurese, to help them to diurese a lot. You have to make sure they are on the appropriate venothromboembolic prophylaxis, DVT prophylaxis, meaning if your albumin is below 2, you need to put them on full anticoagulation, either with Coumadin or Eliquis or direct thrombin inhibitor. If the albumin is above 2, you can give them aspirin. Of course, you have to make sure that they're not anticoagulated as they go through a kidney biopsy. But what will kill these patients actually is DVT. And a lot of these patients do have PEs. Unfortunately, I lost a patient maybe like 7 or 8 years ago where she was not taking her VTE prophylaxis. And infection prevention, you should give them the general recommendation about how to prevent infection. In some situations, since you lose a lot of immunoglobulin in the urine, you have to give them IVIG. As far as giving RAS blockade, that's not very obvious. RAS blockade might be important in the treatment, but initially some of these patients, especially minimal change disease and FSGS, can be hypotensive, and the priority is to diurese them. So typically what I start by doing, I start by diuresing them. If the blood pressure will allow me later on, I will add RAS blockade. I do not want to add RAS blockade and diurese them from the get-go because I might induce an acute kidney injury. So this is a general rule about how to treat any nephrotic syndrome. Now we'll move to the minimal change disease, specifically how to treat minimal change disease or primary podocytopathy. So if you have a new nephrotic syndrome, if the patient is less than 12-year-old, there is no syndromic feature or family history, you move ahead and give them glucocorticoid. If they are about 12-year-old, you're going to do a biopsy and then start the treatment accordingly. So now you make a diagnosis of primary podocytopathy or minimal change disease. The first question that you have to ask at the bedside, is it primary? Is it really primary, immune-related, or is it secondary? So you're going to look for family history. In some situation, especially in kids, we do send the genetic evaluation to see if we have any genetic mutation. You have also to look at the history if they have maladaptive hyperfiltration from reduced nephron mass, for example, post-nephrectomy. If you have viral, we're going to check for parvovirus, we're going to check for CMV, EBV, HIV. And this is for minimal change disease and FSGS. And sometimes also, I did see some cases where we had minimal change disease post, for example, post bone marrow transplant. We did diagnose a patient with minimal change disease in a setting of lymphoma. So you have to look at all of these etiologies before just committing someone to immunosuppression. Following this, you're going to give them some proteinuria treatment. Like we said, the diuresis is very important. So now going to the immunosuppression. After you establish that this patient is actually primary or immune-related podocytopathy, you're going to give them prednisone. And prednisone is given as 1 milligram per kg per day with a maximum dose of 80 milligrams for 4 to 8 weeks. The guidelines do mention 16 weeks. I find it very hard to keep a patient on such a high steroid beyond 8 weeks. So usually I do commit the patient to steroid for only 8 weeks. An alternative will be 2 milligrams per kg every other day for 4 to 8 weeks. And some patients, especially if you're talking about some patients who have metabolic syndrome or who had previous problem with steroid, another approach will utilize calcineurin inhibitor, which is cyclosporin or tacrolimus, and you see the target dose, plus half the dose of the prednisone. Instead of giving them the full 1 milligram per kg, we give them 0.5 milligram per kg, and I'll show you some of the data on this stuff. So you have primary podocytopathy, either you give them the full dose of prednisone or you give them calcineurin inhibitor, and you're gonna follow these patients with routine checkup on their proteinuria, and usually the routine checkup of their proteinuria should be every couple of weeks. So we have 3 potential clinical scenarios. Either you have a complete remission where the creatinine is normal and the proteinuria is below 0.3 grams at 4 weeks, or you have partial remission where you had an improvement, but the improvement was not above 50% and the creatinine might be still is normal. So the proteinuria has improved to less than nephrotic, but still not less than 0.3, and you have no response where the patient is still nephrotic and the creatinine is elevated. So if you have partial or complete remission at 4 weeks, you're gonna just assess the patient. Does the patient is able to undergo additional immunosuppression? You're gonna extend it to 8 or 16 weeks. I usually do not recommend to extend beyond 8 weeks. I start tapering at 8 weeks. One other question that you always have in mind is that you have to reevaluate your diagnosis and see if you're missing on something. Is it possible that this patient doesn't have primary FSGS and does have maybe a secondary etiology or primary minimal change disease? Maybe they have a secondary etiology. Okay, so after extended 16 weeks treatment and the patient is not responding, you have to consider genetic testing and enroll in an appropriate trial. If they are responding, so the complete response, or if they respond or 8 to 12 weeks, you're gonna start tapering the immunosuppression. We do recommend the high-dose steroid to be kept at least for 4 weeks or 2 weeks after the complete remission. And then you're gonna taper the prednisone over six months. There is no standardized way on tapering the prednisone. I usually do a rapid taper initially, so I'll go from 60 to 40 to 30 to 20, and then when I get to 20, my taper will be much slower. So I do every 2 weeks, I go to 20. I go by leap of 20 to 20 milligram every 2 weeks, and then over the next 3 months, I will go from 20 to tapering off the prednisone. And usually if you are giving someone calcineurin inhibitor, you need to continue the treatment up to a year. So as we're tapering the steroid or as we're giving calcineurin inhibitor, we have 3 potential clinical scenarios. Either we have infrequent relapse, which means they have less than 2 relapses per 6 months, or you have patients who are steroid dependent, so which means that they relapse as we are giving them the steroid, or we have frequent relapse, where they relapse very frequently as we are tapering the steroid. If they are infrequent relapse, we just repeat what we did initially. If they are steroid dependent or frequent relapsing, in order for us to take them off the steroid, we do have several possibilities. Either we give them rituximab or cyclophosphamide. So what we do usually, we give them back the steroid or calcineurin inhibitor to get them into remission, and we give them rituximab and cyclophosphamide to keep them in complete remission, or we can give them calcineurin inhibitor for a longer duration. So these are the options. So it's important to realize that rituximab and cyclophosphamide are kept for patients who are steroid dependent, frequent relapse. Usually we do not use them in partial remission or patients who do not respond to steroid. How much time does I still have? 2 minutes?
Yes, please go ahead, Dr. Abdallah.
Yes, about 2 to 3 minutes. Go ahead.
Okay.
We're enjoying the presentation.
Okay, so I want to move ahead and just talk about 2 things that came up this year. The first approach is tacrolimus approach plus high-dose steroid for minimal change disease. What I try to do here, just like I presented in the approach to treatment, is that instead of giving the high-dose steroid alone, they gave a high-dose steroid plus tacrolimus, and they gave a lower dose of steroid, which is 0.5 milligram per kg, versus the high-dose steroid. And then what they were able to show is that when you do this approach, you have a good complete remission, comparable. The rate of relapse was much lower in the patient who were giving tacrolimus with low-dose steroid. This is very important because most of what our patients deal with is the steroid side effect. So I do encourage you, and that's become my practice, is that most of these patients, I do not give them the full dose of 1 milligram per kg. I do give them half the dose, 0.5 milligram per kg, and I add the calcineurin inhibitor to the regimen. And it does work quite well for these patients where they do not run into a lot of side effects. One additional point to mention also, rituximab. As I mentioned, rituximab role is mainly for patients who have frequent relapse or steroid dependency. So as you can see, there is an alternative to rituximab. So after you give rituximab, in order to maintain the remission, you can give them CellCept, and that will help maintain the remission. The problem with CellCept is that they have a high risk of relapse when you stop the CellCept. So rituximab is the ideal medication, or cyclophosphamide. These are the ideal medication to keep someone who's frequently relapsing in remission. So as a summary, primary podocytopathy can present in two histologic lesions, minimal change disease or FSGS. The diagnostic approach should start by evaluating the non-primary etiology and treat the underlying pathogenesis. The approach is based on immunosuppression therapy, steroid as first line. Newer approach are utilizing lower dose of steroid, and they're substituting or utilizing a lot of calcineurin inhibitor. Steroid resistance should trigger the evaluation for non-primary etiology, and we're doing quite a bit of genetic testing these days. Thank you, and looking forward to discuss the cases that you're presenting today.
Thank you very much, Professor Abdallah, for this eminent and brilliant and comprehensive presentation about podocytopathy. I think we can still have 2-3 minutes to hear the comments and have questions from the audience. Dr. Abdallah, I have few comments actually on podocytopathy. It seems that many of the nephrotic syndrome categories we knew in the past are now grouped under this term podocytopathy. And most of these categories actually were steroid resistant or steroid dependent. My question in a nutshell, in a developing country like Egypt, we don't have much access to light microscopy. It couldn't be done routinely in many centers, just the light microscopy and the immunofluorescence. And actually it is difficult as well to do urinary markers of podocyte injury or serum marker of podocyte injury. So mostly we depend on the clinical and light microscopy and the immunofluorescence. Can you please just summarize how we can suspect podocytopathy in such patients based on the clinical and the response to therapy and light microscopy and immunofluorescence?
Yeah, so when you're talking about podocyte injury, these podocyte injury, what matters is what the underlying pathogenesis. And based on the light microscopy, and the IF, you can rule out most of the important pathogenesis that you will approach their treatment differently. What I mean by this, if you see immune complex, for example, in the subepithelial place or in the mesangial place, in this situation, you're going to be thinking about an immune complex process, membranous nephropathy. You're going to be thinking about maybe IgA nephropathy with minimal change disease or lupus nephritis. So really in this situation, you are going to be looking for an immune complex process, and you're going to treat the underlying immune complex process. So the fact that you do not see any immune complex process with a light microscopy that's normal, that will put you in a minimal change disease. And I do not think that you need the EM to confirm this. The other important thing, if you look at an FSGS, and we're going to have a full presentation on FSGS again, when you look at FSGS, where the lesion of the FSGS does help you also identify if it's primary or secondary. For example, if you have a perihilar FSGS, so you have the glomeruli, you have the vascular pole, And if the FSGS is mainly around the vascular pole, you're looking at more of a secondary FSGS from hyperfiltration. If you're having, for example, FSGS at the tip lesion, meaning that the glomerular tuft next to the proximal tubule, where the proximal tubule originate, you're looking at more at an immune complex. If you look at collapsing FSGS, you should suspect viral etiology. So really, I do not think that EM for podocytopathy is an essential thing. It's something that's nice to have. But as long as you can rule out an immune complex process, and you can just actually get a lot of information just by doing the light and IF.
Okay, thank you very much. My
We
second
have,
comment about the use of ACE inhibitor, or angiotensin receptor blockers. I can consider your worry about the use of these two most important antihypertensive and antiproteinuric as well. I think you advised against to start the use of these ACE or ARBs with the diuretics as well. But I think ACE inhibitor as well have a direct effect on the podocyte regeneration and its receptor, isn't it?
Yeah, no, sure, 100%. That's something that you would like to have your patient on. What I caution you about initially is that on the initial diagnosis, especially when you talk about minimal change disease, these patients tend to be on the lower side from the blood pressure, and they do have some of them do have what we call the underfilling physiology, meaning that because they have hypoalbuminemia, their intravascular volume is depleted. So when you give them ACE inhibitor and ARB in the acute setting, they're gonna just go into acute kidney injury. So that's why it's important to stabilize these patients, make a diagnosis, and then start ACE inhibitor ARB after you diurese them or as you're diuresing them. You do not want to just induce an acute kidney injury because that will become a very complicated approach. ACE inhibitor ARB are essential in your podocyte health. So you need ACE inhibitor and ARB, but do not rush and do them in the acute setting the first couple of days when the patient is coming in. It's not diabetic nephropathy. It's not some other disease, membranous nephropathy, where ACE inhibitor and ARB are essential early on.
Okay, any optimistic news about podocyte regenerative therapy?
Excuse me, what therapy?
The podocyte regenerative therapy, the stem cell therapy for podocyte regeneration or so. Do you have any optimistic news?
No, actually, most of what we're doing right now, or most of the research that we're having right now, as far as mesenchymal or stem cell regeneration, is just very early on. Most of them are still in the lab. We do not have anything that's applicable that we can apply now to our clinical setting. I can tell you the treatment approaches or the newer treatment approaches is based on using additional antiproteinuria therapy. So we're looking at, in addition to ACE inhibitor ARB, we're looking at SGLT2 inhibitor, which are a great antiproteinuria therapy, and we're looking at endothelin inhibitor, what are great proteinuria therapy. So these are the newer agents that we are using more and more for the proteinuria part. And the other part that we are looking at as immunosuppression, a better immunosuppression approach using B-cell depleter like rituximab or botenizumab, and there is few other agents that are being looked at as far as specific to podocyte injury. But nothing as far as the regeneration of the podocyte, unfortunately, no, not yet.
Okay, thank you very much, Mamdouh. Do we have questions from the audience? We can get one or two questions.
Yes, we have some questions from the audience. So
can you please read it, Mamdouh?
Yes. So first question is Mahmoud. So if you have a case of steroid resistance, you would not try with CNI. So it is a question. You will give CNI only in steroid dependent or frequently relapser?
So we do not try rituximab or cyclophosphamide. If someone has a frequent relapser or steroid dependent, that's when you give them usually that's when you give them rituximab or cyclophosphamide. If someone is steroid resistant, calcineurin inhibitor will be the treatment of choice in this situation, and you'll go with the assumption that they have a steroid resistant FSGS that's undersampled by the biopsy.
Any other questions, Mamdouh?
Yeah, we have another question. Frequently relapsing or steroid-dependent patient who received rituximab or cyclophosphamide, should this patient be maintained on another immune suppression after rituximab or cyclophosphamide, or just steroid, or you stop immune suppression?
Yeah, we do not have, this is data-free area, and it depends on the patient. So we have patients who we give them once rituximab and they never relapse after. I have a patient, if I do not give her rituximab every 4 months, she goes into acute renal failure and nephrotic syndrome. So her nephrotic syndrome relapse. Why this happened, we do not know. We do not have any data on to guide beyond maintenance. Usually my approach is to give them rituximab or cyclophosphamide and monitor them. If they relapse after 6 months, usually if you give cyclophosphamide or rituximab, you should be good for 6 months at least. If they start relapsing after 6 months or a year, I may just decide to give them rituximab maintenance every 6 months, 1 gram every 6 months for like 2 to 3 years, and then try to take them off. The good news with all of this, minimal change disease specifically, is that these patients tend not to go into chronic kidney disease. So the main problem when they come back, they come immediately, the disease comes immediately, and the proteinuria shut down immediately, and usually they recover their kidney function to a very good level. So really, it's not a problem of loss of GFR every time this happens. The GFR loss is not huge when the relapse happens. It's just more of a inconvenience of giving them lots of steroid and inconvenience with high risk of infection and DVT. So that's why it's okay to try to take them off the immunosuppression and see if they relapse, and then treat them when they relapse.
So
the last question is from Mahmoud Sabh. He's asking about those who are steroid dependent. When we give them CNI, we changed them from steroid dependent. We know the scenario to CNI dependent, I mean cyclosporin or TAG dependent. So he asked, can we stop CNI on them, or do we have any alternative for immunosuppression for this group of patients?
Yeah, that's what I give, rituximab and or cyclophosphamide. When you give, so my approach usually I give them rituximab, and 2 to 3 months after giving them rituximab, I'll take off the calcineurin inhibitor, and these patients will maintain remission. I always tell the patient, counsel the patient, telling them that calcineurin inhibitor and CellCept tend to be like more of a band-aid. So you just put the band-aid, as soon as you take it off, it's gonna just, the disease will come back. So yeah, most of the patients on calcineurin inhibitor relapse, and rituximab or cyclophosphamide will be ideal to keep them in complete remission.
Okay, thank you very much, Professor Abdallah, again for this very comprehensive presentation. And we have to move to the next speaker. The next speaker will be Dr. Ahmad Magdi, a lecturer of nephrology from Mansoura Nephrology and Dialysis Unit. And his title of his presentation will be about